Thus begins chapter 13, part 2. All right, we are getting into cardiac function and the cardiac cycle diagrams, which I have special mini lectures on the cardiac cycle diagrams, but I'm going to go through them again here more quickly because I know I have those additional lectures embedded in you doing the cardiac cycle diagrams. And so you can refer to those as well. Okay, again, the heart is a pump. It is a muscle pump. That muscle part are made up of cardiomyocytes. Those are heart muscle cells. Blood vessels. Those are the arteries, capillaries, and veins, and they are a closed system. So if it's carrying blood away from the heart, then it's an artery. Capillaries, you have exchange with blood and interstitial fluid. And then veins return blood back to heart. So if you're like, what are you talking about? Here's the thing. It's a closed circuit. You have the heart. Arteries are vessels that carry blood away from the heart to all areas of the body. Then you have capillaries where exchange is occurring in tissue beds between the blood and the interstitial fluid. Then that blood is going to return back to the heart. We just now start calling them veins. So arteries are vessels that carry blood away from the heart, and veins are vessels that carry blood to the heart, but it's closed circuit because these vessels start at the heart and they branch and they go to all the areas of the body, and blood flow, all of those different areas have capillary beds where there's exchange between the blood and those cells, interstitial fluid surrounding the cells. Then those vessels just merge and bring the blood back to the heart. Now we're just calling them veins. So those are the blood vessels. Blood, of course, is the transportation system by which things are traveling in this circulatory system. And again, the endocrine system and the nervous system, we'll talk a little bit about that in this lecture. Kidneys, we'll talk a little bit about how they affect blood volume when we get to chapter 14 and again, chapter 18. So in part 1, we talked about the cardiac cycle and what is a cardiac cycle? What constitutes a cardiac cycle? How would you say it if you were going to explain it to someone who had no idea about physiology? So I personally would say a cardiac cycle is one heartbeat, because everyone knows what a heartbeat is. One heartbeat. What is a heartbeat? A heartbeat is the heart filling with blood and then ejecting the blood into pulmonary and systemic systems or circuits, right? That's a heartbeat. Cardiac cycle is one heartbeat. What exactly is going on? So last lecture, we talked about the atrioventricular valves and the aortic and semilunar valves. Now we're going to, and EKGs, we're going to add all this together. We're going to talk about cardiac output and blood flow and what's going on. But first, phase of the cardiac cycle. And again, I have smaller lectures that go through this material in a slightly different way. So between all these lectures, hopefully it'll start clicking, but you have to go over it a lot because at first it's kind of confusing. Because in this diagram, these are the AV valves, and these are the semilunar valves. And so it's correlating the phases of the cardiac cycle with what's going on in the valves. Okay, so phase one, phase one. What is going on in phase one? Well, if we're looking here, blood is passively filling the ventricles. So ventricular filling, it's passive. The heart muscle is relaxed. It is mid to late diastole. Again, diastole means heart is relaxed. It is not contracting. And so blood is coming through the vena cavas, returning from the pulmonary veins, and then going down into the right ventricle and left ventricle. AV valves are open. There is the right AV valve. Here is the left AV valve. Semilunar valves are closed. Heart is filling blood from the atrias into the ventricles. It's passive. AV valves are open. Semilunar valves are closed. And if you look up here, AV valves are open. Semilunar valves are closed. Then the atria contract. So here's where we see the P wave on the EKG. Atria is contracting, so these little arrows here means those little muscular walls are contracting. It forces a little bit more blood down into the ventricles. And that is enough pressure to close the AV valves. So during phase one, it's ventricular filling. The ventricles are filling with blood. It takes place in mid to late diastole. AV valves open, semilunar valves closed. 80% of the blood is flowing passively, but when the atria contract, or atrial systole, which is contraction, it's going to push 20 more percent blood into the ventricle. The volume at the end of this atrial contraction here is called your end diastolic volume because it is at the end of diastole or rest. So the volume of blood in the ventricles at the end of diastole or the diastolic period is the end diastolic volume. That is the volume of blood in each ventricle at the end of ventricular diastole or filling. That's all the blood you get to work with. That's all the blood that's available to then be pushed out by the ventricles contracting. So what happens with this 20% added blood by atrial contraction is that enough blood is forced into the ventricle, and that helps increase pressure in ventricle above atrial pressure. So write down above and then atrial pressure. What does that mean? Another way to put it is This eventuates in ventricular pressure due to blood is now greater than atrial pressure with no too little blood. Causes AV valves to close, and that's going to happen right at the time that the ventricles start to contract. But during this period, this 2A period, all valves are closed. AV valves are closed and semilunar valves. All valves are closed during phase 2A. So if all valves are closing and there is this amount of blood and it's not changing, but ventricles are contracting, ISO means same volume. So isovolumetric contraction phase is when all of the valves are closed and ventricles start to contract. And remember, contraction is systole. So ventricular systole is when the ventricles start to contract. Atria are now in diastole or resting filling, but ventricles are contracting. Isovolumetric, all valves are closed, but so much pressure, the pressure goes up in the ventricle, and that pressure as the muscle is contracting is enough to open the semilunar valves. So semilunar valves open. That is aortic semilunar valve and the pulmonary semilunar valve. The pressure in ventricle is greater than pressure in aorta. So when the pressure is greater here in the ventricle than in the aorta, and same for the pressure is greater in the right ventricle than the pulmonary trunk, the semilunar valves are going to open. And this is happening when the heart is contracting. It's ejecting blood out of the ventricles into the aorta and the pulmonary trunk. So this is ventricular ejection phase. That is 2B. That's when semilunar valves are now open. Blood is leaving the ventricle. So if you look up here, AV valves are still closed, but those semilunar valves are now open and blood is being ejected out of ventricles. As that blood is ejected, the pressure is going to go down. The pressure will be greater in the aorta and the pulmonary trunk, and that drop in pressure closes the semilunar valves. So semilunar valves close when pressure in aorta is greater than pressure in ventricles. Well, why did that pressure drop in the ventricles? Less blood in the ventricle. Less blood in the ventricle, less pressure. So semilunar valves are going to close But remember, atria are having passive filling, and this passive filling of blood back into the atria, you now have a higher pressure in the atria and a lower pressure in the ventricle. And guess what? Pressure is greater in the atria than the ventricle. AV valves are going to open. And so the blood now is passively flowing back into the ventricles. So phase 3 is isovolumetric relaxation. All valves are closed, but ventricles are not contracting. And so that is early diastole, right? Not contracting. And then you start ventricular filling again, and we'll start another cardiac cycle. So this is what the phases of the cardiac cycle are. So whereas this was saying ventricular filling or diastole, this next slide is talking about ventricular systole. So 2A, 2B. Ventricular systole, atria is relaxing, ventricles are starting to contract. Rising pressure in the ventricles result in the closing of the AV valves. Why? 20% more blood is forced into ventricle by atrial contraction. And that's what does the difference. That adds that little 20% to increase the ventricular pressure to greater than atrial closing those AV valves as the ventricular wall is depolarizing and starting to contract. And since all valves are closed, it is isovolumetric, but the ventricle is starting to contract. And that results in the pressure going up to the point where the semilunar valves are opened in the ejection phase. So ejection phase means ejecting blood. Ventricular pressure exceeds the pressure in the large arteries, that is the aorta and the pulmonary trunk, forcing those semilunar valves open, ejecting the blood from ventricle into aorta if it's from the left, or pulmonary trunk if it's from the right ventricle. There is going to be a little bit of volume left in the ventricle during isovolumetric. That is going to be the end systolic volume. Why it's the end of systole. So here we have isovolumetric contraction. Here's where you get the end diastolic volume because it's at the end of the relaxed. So during these isovolumetric periods, here is where you get the end diastolic volume, and here's where you get the end systolic volume. This comes into play when we're looking at stroke volume. So isovolumetric relaxation occurs during early diastole. Ventricles are relaxing. You do have something called a diacrotic notch, which is a brief rise in aortic pressure because the aortic semilunar valve closes. The blood in the aorta kind of come back down and hit that valve and increase the pressure, and you see this on the pressure graph. The cycle is dictated by the AV and semilunar valves opening and closing. And the semilunar valves and AV valves opening and closing is dictated by the pressure produced by either the atria contracting or the ventricles contracting. Now, this is the diagram you guys have in your textbook. Same diagram. It's showing you the pictures along with the phases. It's showing you the AV valves and the semilunar valves and when they're open and closed, and then this are both closed. isovolumetric relaxation, and this is isovolumetric contraction. Right, so all valves are closed here. In both these areas. Now you get to see that they're adding pressure. And this is pressure in millimeters of mercury, and it is the pressure in the ventricle, atrium, and aorta. So what you see here is this is aortic pressure. It's blue. Ventricular pressure is the green line. And then you have atrial pressure is the purple. And this is millimeters of mercury. So from 0 to 110, here's the pressure flowing in the ventricle. This is ventricular pressure. This is atrial pressure. Atria has more blood than the ventricle right now, so it has a higher, slightly higher pressure. At this point right here, this is where the atria contracts and pumps that extra 20%. And that's enough to get the pressure to now exceed atrial pressure. So here is the point where ventricular pressure exceeds atrial pressure. Here's where the atria are now entering diastole or relaxing. Here is the point where the ventricle starts systole or contracting. So here the pressure is rising in the ventricle because all the valves are closed and the ventricular wall is contracting and just increasing that pressure. At this point right here, semilunar valves open. This point here, AV valves close. This is isovolumetric phase. But at that point right here, ventricular pressure is going to exceed aortic pressure. And so those semilunar valves are going to open. The heart's ventricular wall is contracting, ejecting the blood out into the aorta. So ventricular pressure has to stay higher than the aortic pressure, or the semilunar valve will close, the aortic valve will close. But as the blood's getting ejected out, the pressure is going to drop because there's no more blood in the ventricle. And then here is where the semilunar valve closes because ventricular pressure is decreasing, less blood, and the heart ventricular wall is no longer contracting. But the semilunar valves are closed, AV valves are still closed. Pressure is declining because the ventricular wall is not contracting, it's in diastole. And at this point here is where ventricular pressure gets to be less than atrial pressure. So AV valves open. And as you can see, ventricular pressure drops below atrial pressure. Why? Oops. Because atria have been passively filling with blood while the ventricle's been ejecting all their blood. And so now there's less blood in ventricle than in atria. So the pressure is higher in the atria, it opens those AV valves, and now blood is starting to fill back into the ventricle. And we can see this when we look at the volume. This is a volume of blood in ventricle. And by the way, this is the other isovolumetric period. So here, during this isovolumetric period, this volume, and it's 130 mLs, is the end diastolic volume. It's the volume of blood at the end of the diastolic or filling period. Here's where you have ejection of blood during systole. And so blood is being injected until you reach the isovolumetric period of relaxation. This is the volume left in the ventricle after systole or contraction. And so that is the end systolic volume. So you have the end systolic volume, you have the end diastolic volume. And so from those two numbers, we can see how much blood was ejected. By the ventricle. Right? How do you figure that out? Well, you take the volume you started with, end diastolic volume, you subtract the volume of blood left in there, end systolic volume, and this is going to equal something called stroke volume. The stroke volume is the volume of blood that was ejected out of the heart. So we could figure out what the stroke volume is, because if we look, end diastolic volume is 130, and systolic volume is 60. And so we know that the stroke volume is 70 milliliters. So 70 milliliters of blood was ejected out of the ventricle during systole. Heart sounds should make sense. Heart sounds correlate to valves closing, not opening. So the first heart sound you hear is when the AV valve closes. Second heart sound you hear is where the semilunar valves close. We can hear those valves closing. This also correlates with the EKG or the ECG, in that the P wave, where the atria is contracting, let's do pink. If we take the P wave and we follow it up, it's contracting. You see the depolarization here in the P wave, followed by atrial contraction, followed by pushing that extra 20% blood into the ventricle, which then closes the AV valve. So you hear the heart sound as the QRS complex is going down, right? Because we have contraction of ventricle here in this period. And that makes sense because blood is being ejected out of the heart. The stroke volume, pressure also goes up in the ventricle because the heart muscle is creating that pressure. And then we hear the semilunar valves close as the T wave is happening, where now it's ventricular diastole or rest. So this graph is really putting together all of these things, right? Phase 1, ventricular filling. Middle to end of ventricular diastole, blood is returning from the systemic circuit. That is venous return. I should say pulmonary circuit too. So remember, veins are carrying blood back to the heart. So venous return is blood returning back to the heart. AV valves are open. Blood is passively moving from the atria to the ventricle. Pulmonary and aortic semilunar valves are closed. And everything's passive until the P wave followed by atrial contraction. So P wave atria is depolarizing, and then muscle contraction follows. So you have atrial wall contracting. AV valves and semilunar valves are both closed. That's why it's isovolumetric, but the ventricle is contracting, right? Because as we see here, QRS complex is depolarization of the ventricles. And what follows depolarization? Ventricle contracting. So we see AV valves close. We can hear that on a stethoscope. We see ventricular pressure rising. Ventricles are contracting after depolarization. Once the semilunar valves open, because ventricular pressure exceeds aortic pressure, all the valves are opening and blood's being ejected out of the ventricle. We can see that in the volume. So ventricular ejection, this is ventricular systole. Ventricular pressure is greater than the pressure in the arteries being aorta and the pulmonary trunk, followed by branching of the pulmonary arteries. Semilunar valves are open. As long as ventricular pressure is greater than aortic pressure, semilunar valves are open. But when ventricular pressure drops below aortic pressure, then semilunar valves close. So we're going to see the semilunar valves close, and that starts the period of isovolumetric ventricular relaxation or diastole. It's the onset of diastole. Here you can see semilunar valves close. This, by the way, is the diacritic notch. This is when blood kind of bounces back on the aortic semilunar valve and you have a uptick of pressure, but then that uptick of pressure goes back down. So it's just a notch or a bump in pressure. But the pressure in the ventricle is steadily dropping because the heart ventricular wall is relaxing. And so the ventricular pressure is going to drop below atrial pressure. And this right here is where AV valves open. This is that second heart sound we're hearing when the semilunar valve closes. Here's when the AV valves close. And here's where we hear that first heart sound. So isovolumetric ventricular relaxation, it's the onset or start of diastole. Ventricles are relaxing. You have a decrease in pressure, but all valves are closed. No blood is entering or exiting. And you have your end systolic volume at that point, which is going to be the volume here. This right here is your end diastolic volume. So putting it all together, this is showing you the phases. That's a terrible W. What is going on with the valves here? What are pressures comparatively in aorta, ventricle, and the atria? Here you have ventricular volume of blood. Here you have sounds of valves closing. And here you have the electrical activity, which represents systole and diastole. Is it contracting or is it going to relax? This just goes through atrial pressure and ventricular pressure. What's going on in phase one? Atrial pressure rises slowly with filling blood. Ventricular pressure is low. Small rise in ventricular pressure at the end due to atrial contraction, which is following P wave of depolarization. Phase two, you have a rapid rise in ventricular pressure. Why? Because ventricular systole, it's contracting. Atria is in diastole, so it's relaxing. And so this phase two is here and here. So all of this. Phase three, ventricular pressure starts to fall. Atrial pressure falls further until late systole. So both pressures are dropping. Phase four, isovolumetric relaxation, ventricular pressure completely falls. And then we start back over again. So this was the graph I started with. This is from another book. I personally like seeing the EKG up top, and then you have the heart sounds. Here you have, it's the same numbers. This is pressures. This right here is volume in ventricles. And then here it's just valves open or closed. So what's going on with the valves? Then you have picture of what's going on in the heart. Same thing, just rearranged a little differently. So diastole, aortic valves are closed, blood is still leaving the aorta, so pressure falls. Systole, aortic valves are open, pressure is rising with ejection. Highest pressure point, systolic pressure, aortic valves then close when the pressure in the aorta exceeds that in the ventricle. But it has a backflow of blood bouncing off the aortic semilunar valve. And so you have a bounce of pressure, and that is the diacrotic notch. Pressure seen in aorta after aortic semilunar valve closes. Ventricular volumes. Again, I alluded to the volume of blood in the ventricle at the end of diastole is the end diastolic volume. That is how much blood is available to the heart to eject. At the end of the ejection period or systolic period, you have the volume of blood left in the ventricle at the end of the ejection period. And that is how much blood is left in the ventricle after ventricular ejection. Your heart doesn't eject all of the blood it has available to eject if you're just chilling. You're resting. You don't need to do really strong ventricular contractions. But when you start exercising, your heart muscle actually starts contracting harder, just like the rest of your muscles, and it's pushing more blood out with every contraction. So the end systolic volume starts to drop as you're exercising because your cardiac output, your need for blood flow increases. So you're using more of the volume, using more of that end diastolic volume to help increase the amount of blood circulating in your body per minute. So your stroke volume is the volume of blood ejected from the ventricle in each cycle. And here is the formula. Stroke volume is end diastolic volume minus what's left after systole, which is end systolic volume. And you get a volume of blood. And so you can see here, if your end diastolic volume is 130 and your end systolic volume is 60, that means you ejected 70 mLs, which is your stroke volume. So you can see the numbers here. There is something called the ejection fraction. It's a fraction of the amount of blood available to eject and what actually was ejected out. So it's a fraction of the end diastolic volume ejected during a heartbeat or a cardiac cycle. Ejection fraction is important. It's an indication of how effective your heart is as a pump. So if we have a stroke volume of 70 mLs, this is how much blood was ejected from heart in one contraction. So stroke volume is how much blood was ejected from the heart in one contraction. You're dividing that. Dividing by the end diastolic volume, or how much blood was available to eject in a cardiac cycle. This is a fraction or a percentage. If you have 130 mLs of blood available to contract out, and you contract 70 mLs, so this is your stroke volume divided by your end diastolic volume. If you look at that, it's going to be 0.54, right? Because you are dividing 130 into 70. And so it ends up, I mean, I could do the math. So 5, it's 15, 650. You can bring down the 5, you add another 0, that's 4, and that's 12. And so we're rounding up to get 0.54, and then you multiply by 100 to get that percentage. It's 54%. So 54% of the blood available to eject was ejected. from ventricle. Now, this is important number because if your heart at rest cannot at least eject 50% of the blood available to it, you start moving towards heart failure. Heart failure is when your heart as a muscle is failing to eject enough of the blood that's available for it to eject. So it's really a measurement of, is your heart effective as a pump? And it might not even be your heart's fault. You can have a faulty aortic valve that doesn't open all the way or doesn't close all the way. That's aortic stenosis. It's not opening 100%. It's hard to eject a bunch of blood out through a tiny little opening. So your ejection fraction is going to go down. So ejection fraction can be due to a weak heart. The muscle might have been damaged, out of shape heart. But if it's dropping below 50%, there's something else going on. There's been damage to the heart muscle, or there's valve issues. Heart sounds, I think we've gone over that and gone over that and gone over that. First one is AV valves closing. Second sound you hear is semilunar valves closing, and they do it together. And so you can see I'm showing the exact points at which the AV valves, semilunar valves, and AV valves again open. Stroke volume, again. Stroke volume is end diastolic volume minus end systolic volume. Stroke volume is the volume of blood ejected from the ventricles in one cardiac cycle. That's the amount of blood ejected out. That's your stroke volume. The things that affect stroke volume. How much blood did you have available at the beginning? End diastolic volume. It's actually called preload. And preload is you're loading the heart up with blood. How much end diastolic volume? Obviously, the larger the end diastolic volume, the better. And so how do you get that large end diastolic volume? Well, you have a lot of time in diastole, a lot of time between heartbeats. You have a slow resting heart rate. There's a long time between contractions of the ventricles. And the longer you have between contractions, the longer you have to fill up the ventricle with blood. And that is what preload is. Preload is the amount of blood in, that's a ventricle before systole. And that is due to venous return, how much blood is coming back, returning, and how long in diastole. Right? So the longer you're resting, longer you have time to fill, the bigger the end diastolic volume or preload. So that's good. Good. Yay, preload is good. Afterload, bad. Afterload is essentially the pressure in aorta, which is kind of equal to blood pressure, or the pressure in the system, which is your mean arterial pressure. If you have high afterload, that's bad. That means in order, so these are pressures right here. If, say, the aortic pressure is high because you have high blood pressure, right? Someone with high blood pressure, instead of the line being down here for aortic pressure, the line is going to be here. And if the line is here, guess what? The ventricle now has to keep going and get even more pressure to actually open those semilunar valves. And so instead of only needing 70 millimeters of mercury pressure, the heart muscle now has to exert upwards of 80, right? So the heart is having to work harder to get more pressure than the pressure that's in the aorta because that is part of your mean arterial pressure. That is what afterload is. And so afterload is bad. That's the amount of pressure in your circulatory system that the heart has to work against to eject that new stroke volume of blood into a closed system that is already under pressure. It's like trying to blow more air into a balloon that already is completely filled with air. It gets hard. You have to exert more pressure to get a little bit of more air in there. And guess what? You can pop the balloon when you do that. And that is uh, what happens when vessels kind of break. So an example is a dissected aorta. It's when the aorta just basically breaks or splits because the pressure is too high. The heart's really pushing the stroke volume in because it has to, but the pressure in the system, because the person has probably high blood pressure, is so strong that the balloon breaks, the vessels break. So afterload is bad. That's the pressure that the heart has to work against, the pressure in the aorta. And then the third thing is ventricular contractility. Well, if you have a strong heart, then it can contract, a little at rest, more when you exercise a little strenuously. But if you want to win a 100-meter race, it's going to really contract. And so the heart muscle wall can actually vary the amount of contraction. If it contracts harder, it can increase the stroke volume. And so we're going to get into cardiac output. And cardiac output is really what we call your blood flow in 1 minute of time. So how much volume of blood flows through your circulatory system in 1 minute? Cardiac output is either in milliliters per minute or you can do liters per minute. It's a volume in a given amount of time. And cardiac output is equal to stroke volume times heart rate. And so we're talking about stroke volume. So if you have a really high stroke volume, most people only need about 5 liters per minute. If you have a really high stroke volume, you can have a low resting heart rate to hit 5 liters per minute because this is multiplication. So if you're keeping the answer the same, if one goes up, the other has to go down and keep it the same. And so preload is good because a high preload means you have a high stroke volume. Why? Because preload is venous return into the ventricles, which increases what you have available or your end diastolic volume. If you have a high end diastolic volume, you're going to end up with a high stroke volume. Afterload. Afterload is bad. Boo. Don't like afterload because it's the pressure or load that the myocardium or ventricular muscles have to overcome. The load that the ventricular muscular wall has to overcome is really great. It has to contract with a lot of force to overcome that load, puts a lot of strain on the heart. Afterload really is due to, in large part, high blood pressure and then arterial and atherosclerosis. Sclerosis, doing a really bad job there. Bottom line is anything that increases systemic or pulmonary arterial pressure is going to increase afterload. So, high mean arterial pressure, which is blood pressure, a lot of times due to a high afterload, high blood pressure is hypertension. That's leading to a high afterload. Heart has to work longer. Something called Starling's law has everything to do with preload. Starling's law states that the critical factor controlling stroke volume is preload. What is preload? Preload is the degree to which the cardiac muscles are being stretched before they contract. Remember from muscles, optimal actin and myosin sarcomere overlap is going to affect the amount of tension that sarcomere and all the sarcomeres in that muscle fiber can exert. And so if you have optimal overlap of actin and myosin, you have optimal cross bridges occurring, you're going to have optimal or maximal contraction. And with the heart, maximal contraction equates to higher stroke volume. And so in the heart, the most important factor causing this optimal stretch is the amount of blood in the ventricles, the end diastolic volume. And what controls end diastolic volume? Essentially, it's how much blood is returning. How much blood is returning to the ventricles before systole or contraction. So venous return is the amount of blood that's returning to the ventricles during diastole prior to systole. Venous return essentially controls how much blood you're going to have available before systole, which is your end diastolic volume. So anything that slows the heart rate down, anything that increases the amount of venous return. So when you exercise and hopefully you remember from anatomy, your veins rely on the muscles contracting to squish them to get the blood to get back up to the heart. So anything that increases the amount of blood getting back up to the heart is increasing your venous return. So that's why exercise does help increase the amount of blood coming from your toes all the way back up to your heart. You're increasing venous return. So anything that increases venous return or slows heart rate is going to increase end diastolic volume. So the influence of end diastolic volume on stroke volume, again, Starling's law states that an increase in end diastolic volume stretches the cardiomyocytes or heart muscle cells to optimal length, which means max number of cross bridges. Maximum number of cross bridges formed. Number of cross bridges formed equate into the amount of force. Amount of force equates into how much blood is ejected. And so The result is you eject a large volume of blood, you have a bigger stroke volume. So here you increase venous return, you increase the amount of blood returning to the heart. That eventuates in increasing the contractile force of the heart muscle cell, which is going to increase stroke volume. So ventricles contract more forcefully during systole when it has been filled to a greater degree during diastole. Greater end diastolic volume, greater ventricular sarcomere stretch, greater the stretch, greater or more cross bridges formed, and you're going to have a greater contraction. This is different than in skeletal muscles. Cardiac muscle works differently. We don't have this mechanism in skeletal muscles, only in heart muscles. But if you look at stroke volume versus end diastolic volume, if you increase venous return, say you start here at 130 and you can increase it to 210, now instead of only doing 70 mLs of a stroke volume, you're getting 110 mLs. And so if we're looking at cardiac output, at rest, you need only 5 liters per minute. So if you're doing 70 mLs, then and you really only need 5 liters per minute, that means your heart rate can be around 70 to 71 beats per minute because 70 times 70 is essentially 4.9 or 5 liters per minute. And so if you have a stroke volume of 70, great. But what if you need a cardiac output to be 25 liters per minute because you're exercising? You have to increase blood flow when you exercise. So you need to get 25 liters per minute. Well, if you can get an end diastolic volume of 210, and that increases your stroke volume to 110, you do 25, 110. Remember, and we increase our heart rate when we exercise. And so it's much easier, right? So instead of having it be 70 or 80, if we get our heart rate up to 200, 180 to 200 beats per minute, we can get up to 25 liters per minute. So to get our cardiac output, we increase stroke volume and we increase heart rate. If we don't have the ability to increase that stroke volume, though, hard to exercise at a high intensity. So that's why you can see heart disease. If someone has heart disease, you put them on a treadmill and you have EKGs and you're monitoring them, you can really see that they're not able to increase their stroke volume. Their heart rate keeps going up, but they're not able to increase their cardiac output to meet the demands. And so that's part of the things that treadmill tests can diagnose. Ejection fraction is important. Treadmill tests, they're all telling the practitioner how effective the heart is as a pump. And so ejection fraction, again, is the ratio of the stroke volume to end diastolic volume. It is a division, right? So it's how much blood was ejected divided by how much blood was available. Divided by available to eject from heart. And so you're gonna get this ejection fraction, and so we can increase that ejection fraction when exercising. At rest, you may only need 50% of your end diastolic volume being ejected out because you only need 5 liters per minute, but when you're exercising, you need 25 liters per minute. You need a higher ejection fraction, and you need your heart to do it more times in a given minute, and so that's why heart rate increases when exercising, but also ejection fraction, stroke volume. So, uh, this is supposed to be increase in contractility due to increase in the number of cross bridges, due to venous return, right? That'll increase stroke volume and increase ejection fraction. And so you end up with a higher ejection fraction. If if your heart muscle has died, you've had heart attacks, myocardial infarctions, those muscle cells no longer contract, that's going to lead to a decrease in ejection fraction because you don't have those sarcomeres anymore. So you can't produce any force and you're not going to be able to have a very high stroke volume or end diastolic volume. And so your heart is not acting effective as a pump. And I'll show you. If you have to meet 5 liters per minute at a minimum, this is for just cardiac output, and your stroke volume is 54 mLs. What's your heart rate? Well, you basically divide 54, or we can say 0.54 liters into 50. So I'm doing it right now. Like 5 divided by. So your resting heart rate is going to be about 96 beats per minute. That's a really high resting heart rate. High resting heart rates are an indication that there's a low stroke volume going on. And so heart rate becomes a vital sign. Someone comes in to get a physical and they're chilling. They're not really there for any other reason than their annual physical, and their resting heart rate's 100 beats per minute. You have to wonder what their stroke volume is, because it's clearly very low, unless, of course, they've had like 20 Red Bulls or some kind of stimulant. If they haven't done a bunch of caffeine and they have a resting heart rate of 100 beats per minute, then you're thinking their stroke volume is pretty low. All right, cardiac output definition for you here. Amount of blood pumped out of each ventricle in 1 minute. It's akin to what we call your blood flow, or a volume per minute. Cardiac output is the product, which is multiplication of heart rate times stroke volume. Normal cardiac outputs are around 5 liters per minute. Everyone is usually staying around 5 liters per minute because that's our metabolic needs. That's our homeostatic needs. We only need 5 liters per minute. So whether you are an Olympic athlete or an Olympic couch potato, 5 liters per minute is what you need blood to be flowing to get oxygen to your cells, just to do active transport, sodium, potassium pumps, the basics. So basics for everyone. We all need about 5 liters of blood flowing through our systemic circuit per minute and pulmonary circuit per minute for our oxygen needs and our metabolic needs. If your heart is super strong and you have a really, really high stroke volume, then you can have a low resting heart rate because your heart just doesn't have to beat that many times to get to 5 liters per minute because you're just pumping so much blood every time you contract that it's just chilling to meet that 5 liters per minute. So anything that increases end diastolic volume increases it's going to increase cardiac muscle contractility, is going to increase stroke volume. And that in turn is going to lead to slower heart rates at rest. And that's why a low resting heart rate is really, really good. But it's multiplication. So as stroke volume goes down, because you're pumping less blood, then heart rate has to go up. And so people that have a high resting heart rate, typically, again, unless they're on a stimulant, they have a low stroke volume. So heart rate becomes a vital sign. It's an easy way to look at um, the health of someone. Here's an extreme example, super fit heart, pumping 90 mLs per contraction, which is 0.09 liters. If you're pumping this is a really high stroke volume, athlete stroke volume. To meet that 5 liters per minute, heart only has to beat 58 beats per minute. So that's why a resting heart rate of 55 to 60, that's a strong heart. They're pumping a large stroke volume with every contraction. So cardiac output is equal to heart rate times stroke volume. Stroke volume is equal to the end diastolic volume, and the volume of blood in the ventricle at the end of diastole minus what was left over after contraction, which is end systolic volume. And now we're going to kind of bring in mean arterial pressure. But what I'm going to do is I'm going to save this because I think this is so much that we're going to make a part 3 of chapter 13. So stay tuned.